we're trying to connect the dots.
Yes.
We're not trying to find another protocol.
Yeah.
We're not. We're trying to provide the precision, but we have to do that through asking questions. We can only recognize a problem that needs remedy if we know the problem. And so we have to do that through a question, but then with our curiosity in mind, we then seek that out and we seek out others that help us. And then that's where we're going to find a solution or solutions, as is always the case, for the problems.
Welcome to Metabolic Matters podcast. Let's meet today's guest. Welcome to another riveting discussion on Metabolic Matters. And today we get to have an amazing conversation with someone who has just grown to be not just an amazing colleague and teacher and mentor, but also someone who I'd like to say has become a friend over the last few years. And our paths are relatively new in each other's lives, but our common denominator is the patient first and whatever means it takes to bring them back into balance. And so, Dr. Nathan Goodyear, thank you so much for joining us in a very enlightening conversation. I'm sure it will be.
Well, Nasha, I think the world of you, and absolutely, you are a dear, dear friend, colleague, and I would say mentor. We all have mentors.
Right.
And if we say we don't have mentors, then we're in trouble. But we all have mentors and people that keep us on the right track. And you're definitely that, you and your husband, my wife and I think the world of y'all. And it's an honor always to be talking with you.
I love it. It was funny because you and I met, I believe I was trying to figure out, was it at a mistletoe conference, a photodynamic therapy conference, or a Paul Anderson conference where we first met a few years ago?
Oh, I stalked you for a long time. No, I knew about your work because, in this world of integrative oncology, almost every week, one person would say, "Oh, I brought this book here. I want you to read it." Said, "Yes, I've read that." So I became acquainted about your work from patients, which honestly is powerful. Okay. I look at a recommendation from a patient more powerful than a recommendation from a doctor, because that's who we serve and that's the purpose of what we do. But it was the mistletoe conference, basically right, at the tail end or the second half of the COVID pandemic fiasco. But anyways, and so that's where that was. And we were in Denver.
That's right. It was very intimate. I can remember they were having us separated out in tables. We had a mask up most of the time, except when we were sitting in our little spots. It was such a strange time. The streets were still virtually empty in downtown Denver. It was a weird time. And there was quite a good group of us who weathered the storm and came out of the woodworks to be together to learn in person, which I think we were also hungry for human contact. So that was a really good experience as well. And a great group of people that have stayed very close touch and perpetuate that knowledge today. Dr. Nathan, you have such a cool background. I was so intrigued to learn of your background in medicine. It's not like you just jumped right into integrative medicine. You started out in kind of a very conventional as it gets, the world of surgery. So can you walk us through your medical training, where your interest started and what led to this really beautiful evolution and expansion of your consciousness around how to serve your patients, as well as your interest of the tools that you gravitate towards?
So, I was a pelvic floor surgeon. So my primary area of expertise was vaginal prolapse surgery. So as much as I could do through vaginal surgery, I did. We did lots of laparoscopic surgery, open, but it was more around the prolapse and that issue. And I was involved early in that whole vaginal mesh fiasco. And I think that was my first awareness that there was a disconnect between the bureaucracy corporate side of medicine and the actual practice of it. And the person that was getting left out was the patient. And because in the early adoption of that, they told us that we have studies coming. They're in France, they're coming. And they never came. But it also brought my interest in the immune system, because there were studies that came out as we started to discover that the erosion and extrusion issue related to the vaginal mesh, interesting concept, Nasha. The flora, the microbiome of the skin is different than the microbiome of the vagina. Interesting conversation. I don't think your listeners would have thought they would have heard here, But that is a concept that seems obvious to most, but yet was missed on every doctor. And so when they took this vaginal mesh and then we applied it vaginally, it was like, this doesn't work. And in fact, it erodes. So with that, then they started to discover that even when they went in and explanted the vaginal mesh, so they removed it, the chronic granulomatous inflammatory response remained. So
Wow.
that was the beginning of the process. Thankfully, I had a compounding pharmacist that kept talking to me about bioidentical hormones. But I finished in 2004 and got into the integrative movement very quickly in about 2005-ish, early 2006. And it was primarily in that hormonal process because most of my patients were, menopausal prolapse. And so the question of cancer always came up. So
Oh, wow.
do hormones, are they relating to my risk? I had breast cancer. How does this relate? So it was ongoing. And then basically, as I migrated through integrative medicine, as an early adopter of IV vitamin C and other therapies, probably, I think that was 2009. But in that process, what happened is it seemed that patients with cancer came to my clinic and
Wow.
I was providing, adjunctive augmentative therapies to their conventional oncology, nutritional, IV therapy, supplements, that kind of stuff. And so I was in a practice that was wellness. And that's when I think it was the hand of God on my shoulder that said, no, it's time for you to do what I want you to do. And that's when I was diagnosed with the pheochromocytoma, which is the kind of test question you'll get in medical school and say you'll never see it in clinical practice. And I happen to have it. And it was just one of those things that it was like, okay, that's odd. Okay, let's fix it. Unfortunately, I was going to stroke, so I did have to have that surgically resected. My blood pressure was 300/130. It was just like nothing was controlling it. So from that standpoint, then I moved out to Arizona. And because I knew out in
Wow.
Arizona, I could be a licensed MD because I love being a doctor. I love being a medical doctor. I think it's one of the greatest professions that we can have. And you recognize that as a naturopath. And I look at us as co-equals. We just approach things slightly different. But then as an MD homeopath. And so my journey began there. I've run 2 clinics here. And what I say often is what defines me is hope, heal, teach, serve, truth, trust, legacy. These are what define me as an individual and what they define me as a patient. But what I discovered as I moved through the process of taking care of patients, there were a few other principles: innovation, elevation, and empowerment. Because cancer is constantly mutating. And we can't rest on the laurels of what was past. We must. Patients demand it of us. We must demand it of ourselves. We must innovate for the future. We must always do better to elevate the practice, but to empower patients. And, one of my dearest patients, been taking care of her for 4 years. She passed yesterday morning.
Oh, man, I'm
Stage
sorry.
stage 4 breast cancer, 4 years, 4 years. She did great. And she just got tired. It was funny. I was texting back and forth with her husband last night and, he was thanking me. I was, thanking for the time I got to spend with him. But what it left in me was, we must do better. We must do better because her soul was one that will be missed, will be missed. And, but her contact with other people has changed their life as it's changed mine. And so she is emblematic of what it means to be in the integrative cancer space. But her journey and where it ended on this earth is why we must keep pushing.
Beautiful. I feel like I went through a catalog, like a quick flash of every patient like that you just described that has been instrumental in my own learning, my own healing, my own striving to do better. Thank God for those individuals who've come into our lives, even if they were short-lived. And it's interesting. I appreciate that you brought up those moments that even after someone passes, that somehow our standard of care model makes that out as a failure. And yet there's only a few things that are guaranteed in this life. One is birth, one is death, and some might say that the other is taxes. But it's very interesting to me that when you really walk with someone on this journey, that if you are doing the right work with them, that you're doing this in a collaborative way, that the patient is in the driver's seat and you might just be the GPS, that when they do go home, that there's not of course there's sadness, there's a loss, but there's also a beautiful healing into dying and a gratitude for those who are left behind, to know that even dying can have a very different outcome. And even for a strange lack of, description, maybe a sort of success in its own way. Like, don't we all wish for a sort of a good death, a thoughtful, conscious, I've done everything I can and I was walked very thoughtfully and lovingly along that journey? I'm just curious, you brought that up and it touched a chord in me and I could feel the emotion in you, but how do you meet with that? Because as a doctor in general, and as a doctor focusing on oncology in particular, these conversations and these experiences will happen more often, than most professions.
Of course, we want to heal all of our patients. I mean, that is truly what it means to serve our patients. That's our job. The word physician can be translated from Hebrew word rophe, which literally can mean healer. I mean, that's our job. But in that, there are some that can't be healed. That maybe it's because the advancement of disease, there's some, this has been very interesting to me. I've encountered just a few, they didn't want to be. Where maybe they were in a relationship. And I'll never forget a conversation I had with a patient with breast cancer. She said, no, I want out. I was like, I want out? What do you mean? She said, I want to pass away. That's my way out. And that was many years ago, probably first year or so, I was in integrative cancer. That really opened my eyes that what we're doing obviously is seeking to heal people. But in some cases, it is helping them to transition. And we have to recognize that even if somebody is in that process where you think you're helping them to transition, healing is still possible. I've been amazed about situations where I don't think a patient will do well and they do amazing. And then a patient that I think is going to do amazing and it's just they don't. And there's so many circumstances around that, family support, trauma, so many things that go into that concept. Of course, you know that best than most. But I think all of that has taught me to be present to those patients, listen to those patients, and honestly, listen to determine what it is that they want out of treatment. Not what I think they want, but what do they want? And it's been very interesting because sometimes I had a husband who said, I just want to be comfortable. And I was like, that's interesting. So I think we have to recognize, you're right. This battle of cancer, it's an ugly battle. We definitely win some and we lose too many. And that's why we got to keep working. But in those that want just a transition, we have to work with them in that and help them to achieve what they want out of it. But I want to heal as many people as we can along the way.
I love that. And it's like, if that's your common goal, that's what you're focused on, even healing into dying is possible.
Oh, absolutely. I mean, if the body's broken, death could be that healing. And so,
Yeah. The thought that comes to me often in moments like this, when that patient has taken this meat suit as far as it's able to go in this lifetime is, and often I've said this and felt this very, very strongly and very emphatically, that the soul has simply outgrown this container and it's time for a new adventure. It's off to the next thing. And so for me, that's always been a huge comfort. And what I've watched happen is someone's, energy sort of condenses and in such a way that it's a powerful process to be a witness to and present with that in a very conscious way. So I really appreciate that we kind of took a tangent that I didn't expect, but I knew you'd be willing to go there, especially since it's so raw and tender for you. And what a beautiful message that this woman had carried through in this conversation today. So I'm grateful to her for that as well.
Your name's Beverly. Godspeed, Beverly.
Beverly, may your next adventure be an amazing one. And so one of the things I always like to hear from, like, how do you, sitting on an airplane or in an elevator, what is your spiel when you describe to people what it is that you do? Like, how do you define integrative oncology or your approach to this field?
Oh, I love words. I love to write. It's, when people say, I'm gonna go golf on Saturday, I'm gonna work on the art on Saturday, I'm gonna go watch a movie. All right. It helps me to, I think, take the organized chaos in my head and to provide it in some structure. That word integrative, comes from a Latin word integrationum, and it could be from an etymologic perspective, meaning from a root origin word, it can mean to restore, remake, renew. And so from my perspective, integrative oncology is the targeting of cancer, but not to turn the body into the battlefield. This idea of going to war on the body, enough war. 1970 war, Nixon declared war on cancer. No other diseases had war declared on it. And yet here we are, 53 years later? Now, there's been some advancements, but people talk about war, and with everything going on in the world right now, obviously that becomes front and center. But here's a war that has cost more lives, that has brutalized more people, turned more people's body into battlefield. And so it's to recognize that what we are is to target the cancer, but it's to restore, it's to remake, it's to renew. And so we can target cancer. We can eliminate cancer, but we must not destroy the immune system. We must not turn the body into a battlefield in that process. And so I think we need a change of thought process in how we approach cancer, honestly, disease for that matter, where we target the tumor, but we must coincidingly help the body heal. Because if we destroy the body and then say, okay, on the flip side, now let's try to recover. And it's like, what's to recover? So I think that's how I would describe it. It's to target cancer, but to restore, remake, and renew the body, because that, after all, is what people are after when cancer treatment. It's to live. And so if we destroy their capacity or quality of life to live in the process, what have we done?
This is huge. And, you are no stranger, as you alluded to, of bringing on innovative therapies along your whole amazing career, as early as 2005, 2006, starting to dabble into integrated, into high dose IV vitamin C and others. In the times that I've known you, I've seen you having interests expand beyond other tools in your toolbox as well. I would love to hear from you, kind of maybe like your top, what are the top 3 areas that you think have the most potential to be of value in the cancer care environment?
Wow. So if I got stranded on a desert island, what 3 things would I take with me? I would think one aspect is, and I'll say this in a term that's not tied to the gut, but the microbiome. Because, people talk about the gut microbiome, and really when you look at the concept of the gut microbiome, we really don't know that much. But we're now starting to discover that there's a tumor microbiome. And in fact, some of the literature looking at pancreatic cancer, they actually suggest that the microbiome of the pancreatic cancer is a better biomarker than the CA19-9 itself. It plays a role in resistance. It plays a role in, we can target that. And we actually know that a fecal transplant can seed the pancreatic cancer. So is it a means for actual treatment? But we now know that even areas that we thought were sterile, such as the brain, there's actually a microbiome in the brain. So I would say one aspect of just the innovation idea is the microbiome, using the gut microbiome as a testing strategy, but as a treatment strategy. But then I would say more so the tumor microbiome. Now, where is that going? We don't know. And obviously the microbiome doesn't just include bacteria. It's viruses, it's biofilms, it's so many things that come in together. So I would say number one, it's the microbiome. Number two, I'm a big fan of CBD. I've talked about that a lot because I hate narcotics. I hate opiates. Yes, I understand we need those at a time and a purpose, but I think they do such damage. I mean, you look at the fentanyl crisis, how many lives have been lost because of that. And when you look at phytocannabinoids, we are still stuck in a make love, not war mentality of the 1960s and 70s as it relates to cannabis. CBD is not cannabis. And so this concept leaves out so much opportunity to help patients. Now, granted, so much of it is preclinical in its scope of knowledge as it relates to CBD. But my goodness, if just a fraction of what the preclinical studies tell us about its anti-cancer mechanisms, it's important. It's important. We must discern it out how to utilize that. But then tying into the third part, and this can bring in a lot of things, it's the immune system. And of course, vitamin C ties into that. Vitamin C is always going to be that flagship of integrative oncology. So we don't need to shy away from that. Recent study, vitamin C, 75 grams 3 times a week, augmenting Gemzar and Abraxane in pancreatic cancer, doubling the overall survival, doubling.
Amazing.
And it's like, wow, come on. They probably still underdosed it for some of these patients. But CBD, looking at the endocannabinoid system and how that interacts with the immune system, we know that CBD downregulates some of the enzymes that are upregulated in cancer that then produce, guess what? Arachidonic acid. And arachidonic acid within the tumor microenvironment is going to, cause recruitment of myeloid-derived suppressing cells to recruit T-regulating cells and lead to an immunosuppressive state. But CBD can actually reduce that. So the best answer to cancer is never get it. The third part overall, it's the immune system, how we target that, whether that's with repurposed medications, whether that's with, CBD, whether that's with the fecal gut microbiome, fecal transplant, diet, all of that. So I would say those are the three things. And the immunotherapy, I know, is a broad topic, but that's what I would say are the three most important.
Well, I want to break down a little bit more of each of those that you said, because there's so much here. Like, I'm assuming that some of our listeners are really well versed and will know all the things you're talking about in full glory. But I'm also assuming there's a lot of people who are hearing this like, wait, what? What did you just say? So let's go back to the very first one. You mentioned fecal transplant, aspect, or the microbiome. And so fecal transplant, can you first of all define what that is, help people understand, because it is what it sounds like, but maybe give a little more information around it, and maybe sort of its general clinical implications, and then maybe drill down a little bit further about a few other things you've learned beyond the pancreatic study of its cancer implications.
Yeah, so I'd love to see those kind of pop up kind of cartoon, of what people would think. And it's like, okay, it's not that. Basically, it's the transplant of microbiome, so bacteria, but other things. Okay, it's not just bacteria, but there is probably mostly bacteria and biofilms into the colon to repopulate. So we have to look through the language of transplantation, because that is what it is. It is an organ that we are transplanting. And so engraftment is important here. And so we have to think in that concept. So engraftment into the gut to optimize the microbiome, and then that impact is on the immune system, but there's metabolites and there's other things. Like I said, there's seeding, but it's the impact on the immune system. And when you look at the animal studies on immunotherapy, where there's a non-responsive tumor type to immunotherapy. So take another side, whoever comes up with the names of these monoclonal antibodies, inhibitory therapies, they should be tarred and feathered. You can't even pronounce them. So
thank you for that.
It's like ridiculousness. I do more reels that I have to reshoot because I can't pronounce the names. But
Right.
so where you have a cancer that's, quote unquote cold, it's not immunoresponsive.
Yes.
And the fecal transplant alone will increase the responsiveness of the tumor to the immunotherapy. That right there shows you the power of
Yes.
that fecal transplant or gut microbiome on the immune system in combination with these are more of the immune checkpoint inhibiting therapies. But we have to think anything that's affecting the immune system is immunotherapy.
And I think, first of all, you just hit on, I'm so glad you brought up about especially relationship to the microbiome and fecal transplant in its responsiveness to these checkpoint inhibitors or these immune therapies that are on the market today. One thing just to clarify for the listeners is that these transplanted microorganisms, whatever they are pulled from quote unquote theoretically healthy individuals. And these, like for instance, like with the immune therapy, this is somebody they say, hey, this person was a really good responder to X, Y, and Z therapy. And so we want to understand why. And it turns out that they had a certain sort of fingerprint of their microbiome that seemed to lend itself to a better response to particular medication. So for the listeners to understand right off the bat that your microbiome matters with how you're going to respond to any drug at all. And so the idea, like we learned a few years ago, Doc, about, if you give antibiotics within 6 months of most chemotherapies, the chemotherapy or the immune therapy are sort of rendered useless or less effective. So we do want to be thinking about that. And so they're like, literally take the poop of someone who had a really good response to something and process it in a way we can re-inoculate it into our own bodies to help create or try to reproduce a high response like that other patient's microbiome allowed for.
When you look at politics, I hate to bring that in because that is, it's a 4-letter word that's not a 4-letter word. But when you think about it, it is, people talk about a legacy of debt, right? They're like, we're leaving a legacy of debt. Well, what have we done? We've left a legacy of disease because when we talk about the microbiome, it's not something that maybe 45-year-old, 65-year-old, because most people think of cancer as a disease of the aged, meaning 60s, the 6th, the 7th, and 8th decade. But why are we seeing colorectal cancer at 29? Why did I talk to a stage 4 breast cancer patient from Canada that was 26 years old? Why? Well, it's because, I came from the OB world, the GYN mostly, but OB. What if a mother doesn't give vaginal birth? What happens? Well, we know that the gut microbiome of that child's different. What if she doesn't then breastfeed that child? We now know that gut microbiome of that child is different. And we know that those lead to obesity risk. And then obesity increases the doorway to other diseases, chronic inflammation, pancreatic cancer, breast cancer, colorectal cancer. There's a great quote from Seth Godin talks about what education does well, that it teaches us to collect the dots. And it doesn't teach us how to connect the dots. Now, I connected a dot there and I did a social media reel, and I think the mothers thought I was calling them out. It was like, oh dear, I opened a hornet's nest. But that's not what my intention was. Because it's like, okay, if you have a mother that has to give birth via C-section,
right?
Do everything you can to help her breastfeed. Or maybe we reach a point where we can actually inoculate that microbiome of that child to protect against that. But it goes deeper, because what if it's not the birth of the mother to the child or the lack of breastfeeding? What if it was what she got from her mom?
Exactly.
Epigenetic transgenerational inheritance. What we do, every choice we make, everything that we do changes our genetic expression, and it's inheritable. It can be transmissible. And so I think that's the only way we can explain how, America and the Western world has become so obese so fast.
Yeah. In such a quick.
Yeah. It's the only way.
Yeah. Well, and it's an interesting thing is, first I want to go back to the conversation. I think this was really a good point. Sometimes when we educate in this platform and you educate in your social media reels and other pieces, people can sometimes make a wrongful assessment that we are pointing out blame. And so I really appreciate you brought that up, because what we're doing is we're being messengers. We're pointing out things that you don't know what you don't know until you know. And so one of the things, if someone is listening and they hear about this, it is not too late to inoculate that baby who's been born C-section. So when I created birth plans with my patients while I was in private practice, this is years ago before we knew definitively what we know today about the microbiome, I would explain to mothers that if for some reason the plan goes south and you end up in a different approach, either knowingly or unknowingly as a C-section, especially if there's a planned C-section, we really prep them for this ahead of time. But a non-planned one as well, we say, if this happens, you're literally going to reach on up inside there. You're going to take all that juice and you're going to smear it all over that baby. You're going to put it up their nostrils. You're going to put it into their ears. You're going to put it into their mouths. You're going to rub it into their eyes, and you're going to rub it around your nipples. And you're going to put your skin against them as much as possible and inoculate them, because your first inoculation of a good microbiome is through the vaginal canal. And if they can't go through your vaginal canal, you can bring your vaginal canal to them.
I can just see a marketing campaign around that just would not be so good.
This is like the point. And then you say like, okay, you can't breastfeed. Well, what's the next best? It's like, well, maybe you reach into some biobanks in your community. Maybe you look around your circle of peers and like, who's breastfeeding and has excess that I can, even putting a little bit, an ounce of somebody's breast milk into their formula is a way to inoculate. There's always a way, I guess is what I'm trying to say. So when we are educating and tell you things that make you go, oh my God, I didn't do that, so therefore I'm at fault, that is never what people like Dr. Nathan and myself are doing. We're trying to help you understand the why, because the why becomes increasingly obvious over time. And then that complete sort of talking about the wrong pandemics, the pandemic of things like glyphosate into our soil is an antibiotic. And so this has completely changed our microbiomes. And that became sort of ubiquitous into our soil in 1986. And now it's even in our rainwater. So even if you're eating organic, you're still getting glyphosate. So we've messed up our microbiome. So I just want to really drive that home so folks understand there's also ways to dissolve the glyphosate, have your shots of organic raw, sauerkraut juice every day so that you can use the humic acid, the fulvic acid in that to break down the residues of glyphosate. Those are examples that people like Dr. Nathan and I are trained to understand how to help you overcome some of those barriers. And so I love this. Yeah.
Yeah, I think what's unique about you, and you look at that instead of connect, is people like you and people like me, and I think we're kindred spirits. We always seem to find each other because we're trying to connect the dots.
Yes.
We're not trying to find another protocol.
Yeah.
We're not. We're trying to provide the precision, but we have to do that through asking questions. We can only recognize a problem that needs remedy if we know the problem. And so we have to do that through a question, but then with our curiosity in mind, we then seek that out and we seek out others that help us. And then that's where we're going to find the solution or solutions, as is always the case, for the problems.
And I want to come over to cannabis because, like you said, I really appreciate you talking about kind of the stigma and the sort of hangover or leftover residue of looking at this as sort of the
Cheech and Chong effect.
Yeah, totally. The gone craze or whatever. And you're speaking to a very particular chemovar or component of a plant that has huge utility that was all but suppressed in research on it. We knew back in the early 1900s that this had impact, but we made some changes in our governmental policies that suppressed us looking at it and asking any questions. And you mentioned that we kind of quickly adopted post-World War II into the, what's now turned into like the opiate crisis, which is one of the contributing factors to our diminished life expectancy in the United States is opiate overdose. I also, could you speak to, I want to flesh out cannabis a little bit, but I also want to speak to, you talked about your distaste for opiates. Now, you also mentioned time and place, but they tend to be a first resort than a last for folks. Can you speak to some of the evidence about the impact of opiates on cancer cell proliferation?
Wow. Well, I would say to get to that question quickly, when you look at some of the opiates, it doesn't apply to all of them, at least per what the literature suggests. And again, I think we have to have this clarifying. We have to always be honest about what the literature shows because they've asked the questions. And then we also have to be honest about what the literature doesn't show because the question has not been asked.
Nice. Yeah.
And then what's the limitation of the research? So for example, when I talk about the integrative therapies, I'll say, well, understand the limitations. This is all preclinical. There's no human clinical trials. And so this is great, but we have to recognize the limitations. When you look at a lot of the opiates, the impact beyond the constipation issue is, my concern is on the immune system, the immunosuppression.
Yes, that's big.
And so that, in terms of when you look at cancer's rate limiting step, if you will, people talk about, well, it's when it invades. Well, what I would tell you is 90% of morbidity and mortality in cancer occurs when it spreads, when it metastasizes.
Yes, yes.
And so if we then suppress the immune system, that is leading to the key aspect of how that's leading to the rate limiting step. That's immune evasion. When cancer evades the immune system, then that's where it leaves the nest. And it doesn't leave in isolation. It leaves in a kind of entourage. It brings its entourage with it, platelets and fibroblasts and other things. So don't think it goes alone. But opiates suppress that immune activity. And so that's my great issue with opiates. And I think in a lot of ways, it does negatively impact quality of life for some of these patients as well. Definitely, it can be helpful. But what I've noticed is through the use of repurposed medications and CBD dosed properly, maybe sometime medical cannabis, THC, I focus more on the phytocannabinoids and the ratios, but we can use the opiates in more of a breakthrough perspective. So they don't become the dominant, they become the breakthrough. Okay, for whatever reason, pain is spiking. Okay, we can now bring in oxycodone, hydromorphine. We can now bring that in, but then we have to adjust the baseline strategy. And the baseline strategy is one that has the dual mode of pain relief and cancer treatment. And opiates don't.
So good. And so what a great clarification that it's not that the opiates directly induce cancer cell proliferation, but they allow for a vulnerability for tumors to evade the awareness of the immune system so they can move out and around the building it more freely. So I love that.
A lot of people would say, well, certain opiates haven't been shown to do that. It's like, well, no, they've not been looked at.
Exactly.
They've not been looked at. So no, don't take that jump, because if I take that jump, you're going to criticize me, as you should, but don't you take that jump.
Well, and it's interesting because one of the therapies that we use, and one of the repurposed drugs, we'll go there here in just a moment, but one of the repurposed drugs we used is low-dose naltrexone, which is actually changing what it's helping with that immune surveillance, and it's blocking an opiate receptors. And so it's very interesting. I don't know if you want to tackle that now or wait a moment for us to get into the off-label drug talk.
Well, I wonder, and I've not had a chance to do a deep dive on it. There's so many hours in the day, but one of the things that I've been really looking at recently is the interconnectivity between the endocannabinoid system, the endogenous, right? Anandamide and 2-AG, because I can't pronounce the name. And then the enzymes that they're involved with, and how that interacts with the immune system.
I love it.
It is a complicated milieu for sure. And I'm wondering, because when you look at CBD, everybody thinks about CBD1, CBD2 receptors. Honestly, I don't really know what the impact is there. CBD2, mostly peripheral immune cells, CBD1, CNS. But the connection here between those, I wonder if low-dose naltrexone is having an impact there, because CBD, we know, binds to opioid receptors. It impacts serotonin receptors. So I'm wondering if what low-dose naltrexone is bridging this interconnectivity between the endocannabinoid system and the immune system. I don't know.
I did a talk a few years ago at a massive immuno-oncology event, and my topic was the impact of LDN and the impact and interaction between LDN, low-dose naltrexone, and cannabinoids. And I broke this down, and I was really nervous because I'm speaking to one of the people in the audience was Dr. Angus Dalgleish, who is a well-known, world-renowned immune oncologist. I mean, just to give you guys a framework, this is the man who discovered CD4 and CD8 cells.
Oh, wow.
Yeah. And he also discovered toll-like receptor.
I love that.
Right? So he's made these bridges for 40 years of understanding this. And it was really fun because there's a beautiful interplay, and he does it far better than I, because this is not my jam, but the listeners and you, Dr. Nathan, and I will connect you guys, and you can go down the rabbit hole of his work. Talks about the interrelationship between the endocannabinoid system and the endorphin system. And this is where there is a beautiful interplay. And I think that we are just at the tip of the iceberg of the research that can be done here to flesh it out even more fully. Because there's even conversations like our beautiful colleague, Dr. Paul Anderson, is like even looked at when you time the giving of these. Sometimes you want to give low dose naltrexone away from, CBD. So you're getting different effects at different times and impacting. So I am very, there's definitely a bridge. There's someone who's got expertise in this, but I still think it is an early on in the amount of research that really needs to be done here. So I would love to throw this onto the table in your free time, Doc. You can go down some rabbit holes with this one.
I'll have some fun. And by the way, you bring up a good point. Two of the best docs I know, number one, you, and number two, Paul Anderson. You're naturopathic medical doctors. There are still states in this country that don't recognize naturopathic medicine. That needs to change. There's been too much of a monopoly in medicine in the United States on the conventional strategy. We must be diverse in our thought. We must challenge our thought because that's the only way we bring innovation. That's it. And so we got to get away from the monolithic thinking that has dominated medicine for the last 100 years or so.
I'm so grateful for that. And it's funny because naturopathic medical schools and homeopathic medical schools were the medical schools of the United States in the late 1800s and early 1900s until the Flexner Report. And so I love that you also came to a state that's sort of the cowboy state. That's part of why we're building the lab and the hospital and things we're doing in Arizona. Because when I was in my training as a naturopathic doctor, I was doing rotations in hospitals. I was doing rotations in ERs. I was doing rotations in family practices and in AIDS clinics. And those doctors were doing rotations in naturopathic, homeopathic, acupuncture environments. So what's really cool about Arizona is that for the most part, they play very well with each other. They appreciate the gifts, the perspectives, the philosophies in which we all have the patient in the center of our equation, but we all might have different strategies of reaching that patient and different philosophies of reaching it. So I'm really grateful that you brought that up because it's a joy. I mean, even in our community, and Dr. Nathan brings so much to our network in that we're like everyone's at the same table together, the DOs, the MDs, the naturopaths, all of us are having these very meaningful conversations. And so I really appreciate you bringing that up. And that's just it. Keeping that curiosity alive, looking through different lenses, through different perspectives, because we get stuck. Science doesn't move if we stop asking questions.
No, that's what drives science. It's that curiosity mind. What we have right now is a discouragement of that curiosity. We have a movement to control groupthink, to focus on the narrative and not focus on the patient. But when people look, I'm an MD and I love being a doctor. And people think on one side, well, if you break a hip, then people that are in the integrative world just want you to take more vitamin D to fix that broken hip. It's like, that's silly. No, surgically repair that.
Right.
And so we have to recognize where everybody fits in that model. And by working together, I love talking to oncologists. Love to. Do they like talking to me? Some, yes. A lot, probably no.
Yeah.
But I think if we say, look, this is about the patient, then that gives us the ability to bridge. And that's something that I want to really focus on in the future, Dr. Winters, is building bridges.
Yes.
Because that's the only way I think we help patients.
I love it.
And I think that has to be an emphasis and a focus on what we do, because there's too many name calling, too many finger pointing. And I think sometimes that's necessary, but I think we need to build more bridges than burn.
I love it. And one of the most powerful places where we can build those bridges is also an area that you've taken a keen, interest in and curiosity with, which is that of the repurposed or redo, off-label drug approach. And so you're actually bringing a course to our community for the clinicians to help them have a better understanding, because there's a lot of misinformation out there in the world about this. And you are so right on. We need the bridge. We need a common language and we need a common understanding so we can bring folks to the awareness that we do actually have a lot of pharmaceuticals that are already have gone through all the years, decades of trials, safety studies, et cetera, that are already in our pharmacopoeia that may have other utility that may be less toxic and can be used as very unique scalpels in our situation. Can you give us a little bit about the repurposed drug movement and your interest in where you think it's going and how it could help in the integrative oncology space?
Wow. When I left where I was at recently in the leadership role, because I knew I had to work to innovate. When I left, I had no job. And you know that because I met with you. I was like, I don't know what to do. And you were like, well, don't do brick and mortar. And now I thought, well, that's crazy. And now I'm like, what? She's onto something there. But, so we would do all this long form content because I love to empower patients. But then we lost all that. So I had to focus on the short form content. And so I just did a few quick reels talking about ivermectin and hydroxychloroquine as what some of the research suggests and how it could be used in cancer. And the comments that I saw in the section below was, hey, here's how to make your hydroxychloroquine at home. Hey, here's how to dose. I was like, uh-oh. So from that standpoint, I was like, okay, there is clear a need to empower patients, not to make recommendations in that setting, right? Because why are patients seeking out repurposed medications on their own? I think number one is they want something that they can control. They lose control when they're diagnosed with cancer. Number two, they need something that they can afford. Repurposed medications are in many ways much cheaper than a lot of the conventional therapies. And it's something that's for the most part readily available for the most part. Now, why are they seeking it on their own? It's because their conventional cancer doctors have turned their back on that concept. And so patients are left for their own. But it's interesting the opposition that we have, Nasha, because we have people that complain all the time about maybe a post that I make, but the post I make is actually talking about a study, right? It's actually talking about a study. So, repurposed medication give multitude of opportunities to patients. So take one example. I know nobody's ever heard of this drug. I know they've never heard of it. It's called ivermectin. So let me educate you a little bit. It's an antiparasitic. It's been around for a while. Yes, it was first used in veterinary medicine in 1987, 1981, but it was actually FDA approved in 1987 or 86 in humans. Yeah, that's right. It's not a horse dewormer. It's actually a human dewormer. But what if we were able, going back to the immune system, what if we were able to take a cold tumor, meaning a tumor that's not immunoresponsive, and then make it immunoresponsive through ivermectin? And that's one of the benefits that ivermectin has been shown to do. Now, dosing it and those kind of things are another issue because typically dosing as a repurposed medication in cancer is not the way you would dose it as it relates to its original FDA approval. But I think when we look at medicine too, where it's really interesting, after the pandemic, it was already leading that way. The trust of the average citizen in doctors and in medicine, I think it was at 40%. I think it was a New England Journal of Medicine article.
Wow. It's unfortunate.
And part of it, I think, is they see the costs and they're like, I can't afford this.
Yeah.
Can't afford this. Well, what if we're able to reduce costs simply by using drugs that have been around for 100 years? They augment the conventional therapies. We're able to reduce the dose of the conventional therapies. What if maybe that's the bridge? And I think conventional medicine thinks we're wanting to replace whatever they're doing. And we go, no. We can make what you do better.
Exactly.
Better. And then maybe lower your dose.
Yes, exactly.
And that's the concept of repurposed medications that is so dramatic. Propranolol, beta blocker. People go, oh my gosh, beta blocker. Right. But if you have a high strung individual stressed, you check their neurotransmitter cortisol, they're off the chart. Propranolol can really calm down that stress response that favors immunosuppression. Now, there's natural therapies to use there as well. Ashwagandha, L-theanine. I've been going down some rabbit holes on L-theanine in cancer. Oh, and it's like, oh, I love that because I love that. But I think it is a super exciting area. But here's what's interesting, and here's a little bit of what's frightening. The censorship
Yeah.
that happens there. I mean, I did a post on hydroxychloroquine, and amazingly enough, the platform where that was posted, they lost the audio. They just lost, no, they didn't lost the audio, it was shadow banning. I mean, but because I was talking about studies that talked about hydroxychloroquine.
Yeah.
So we just reposted it. So, but yeah, but that area is where so much censorship happens. And people go, why don't doctors speak out?
Mm.
That's why. They threaten their license. They threaten their livelihood. And you've seen this over the last 4 to 5 years.
Over and over.
And so that's why doctors don't speak out, but they should. They should. And repurposed medications, they're kind of a flagship, kind of like vitamin C.
Yeah. Yeah.
And I think they give power back to the patients. And we need to figure out, Nation, you probably have a good idea because you build bridges.
Mm-hmm.
How do we build this bridge with oncologists to show that this is not a threat?
Mm.
Don't turn your back. Let's meet. Let's work together because it's together where we help that patient.
I love it. And, I have an answer for you today. It's available. One of our beautiful colleagues, Travis Christofferson, who wrote the book, Tripping Over the Truth, who's talking about a bridge. He took an incredibly heady technical book by Dr. Tom Seafried on the metabolic, cancer as a metabolic disease. And he sort of took that book and he took Dr. Siddhartha Mukherjee's book, The Emperor of All Maladies, the biography of cancer, and he condensed it into a very digestible, layperson friendly, but still pushes your scientific intellect book called Tripping Over the Truth, which kind of breaks down a little bit of the cancer industry, the cancer history, and this emerging understanding of cancer is more beyond a genetic disease. His follow-up book, Cured, is the one that came after this, goes into some of the concepts of repurposing. He touches on it in Tripping Over the Truth. But he has partnered with a company for a data platform that is evaluating this, is creating that absolute bridge. So you get a patient's tissue or blood assay, you run it through this platform, you look at their targetable, actionable targets, and you say, show me all the data. And you can qualify it, whether it's in vivo, in vitro, animal, human, blah, blah, blah. They bring it into like categories to say, show me the best of the repurposed drugs that seem to relate to this particular pathway. So it's bringing that bridge of communication and doing the legwork, which is an enormous undertaking, as you well know, as you've been researching this, to have it literally at the fingertips of our community, of our conventional and our integrative oncology world that's recognizing that there are many roads to Rome and that there's a tool that helps make this more actionable and scalable in day-to-day world and reproducible as well as measurable. So we can actually see, okay, they have this target, we gave this treatment, let's retest and see if they have that target anymore. It's like we can use this as the bridge. And so I get so appreciative of seeing innovations like this that are taking our anecdotal clinical bedside experience to the bench and the bench to the bedside. This is where the magic is happening. And Dr. Nathan, you're one of a handful, but hopefully growing community of innovators, of curiosities, like your curious nature and your passion and purpose to change this narrative and change the outcomes. And so in that, you are the bridge builder already. It's been evident in all the time I've worked with you and patients I've had in common with you. But I would love for you to leave kind of something you might leave as like a little hope bubble for folks. What do you think the future holds in the space of integrative cancer or cancer care, cancer outcomes that you want to leave our listeners with today?
That's where I think the light shines the brightest, because I think, and that's why I left, because I knew I had to keep pushing. Of course, I landed with Williams Cancer Institute and colleague that I went to medical school together with, and he's innovated in the approach to cancer. I think the future of cancer care, of course, it's precision, it's multi-omics, and we didn't even touch into that, but the concept of what cancer has been, surgery, chemo, radiation, I call them the unholy trinity. Those three, yes, they've had some wins in childhood leukemia. We have to recognize that, but they have done a lot of harm as well. And so just because there's wins doesn't mean we don't strive to do better. So I think where we're going is we're going to be innovating where we are innovating in terms of intratumoral. So we've all gone systemic to tumor. That's been the whole approach. Go through the body to get to the tumors. A lot of problems with that, off-target toxicity, all the issues of getting, plasma therapeutic levels, getting the extracellular space, get to the tumors and saturate them and affect them. What if we just go right to the tumor? What do we just go right to, if systemic immunotherapy, 15, 20% response rate, a response rate, not 100%, a response. Well, the tumor microenvironment buffers. It got the pH buffer. It's got the immune buffer. It's got all these buffers, the matrix that keeps these drugs out. Well, by going into the tumor, we completely bypass all of that. And by using for example, pulse electric field therapy, cryoablation, what we're doing is we're targeting the most active component of the most active tumor. That in turn leads to new antigens. Then we inject a variety of maybe immunotherapeutics. And a lot of people think drugs, yes, they can be immune checkpoints. They can be nucleic acid sequence. They can be natural. This mistletoe, CBD, curcumin, all can be given intratumoral. And one of my favorite is artesunate.
Yes.
Approved. Now that's a repurposed drug too, because that's approved for malaria, but it is a TGF beta inhibitor and an advanced cancer. That is key. So if we are able to then activate, train, and harness the immune system against the tumor, and then allow the immune system to do what it does best, go out and then activate the rest of the immune system, then maybe our rush to, have a impulse buy, and then we have regret. Maybe the strategy to cancer is actually slow and steady wins the game, wins the race. Because, and you're a perfect example of that. If we are able to empower the immune system every day, and more cancer cells die every day, and that's a strategy that builds day upon day, week upon week, month upon month, and we do so in a way that's achievable, reproducible, and it's cost effective. And then patients can actually maintain and sustain a high quality of life. So thus live as they undergo treatment.
Yeah.
I think where we are at the Williams Cancer Institute and what others are doing like yourself, when we start to all go, wow, this is really interesting. It all works together. That's where I think what we do in the future of cancer care in 10 to 15 to 20 years, it's going to be night and day different.
I can't wait.
It's going to be night and day different. And I think you're going to see patients maintain a high quality of life as they undergo treatment.
Yay, and yay. Doc, where can people follow you? You have the best reels. By the way, you also have the best shirts, which I've talked about. So you guys have to follow him just to watch what shirt he's wearing. Tammy does an amazing job helping you source them.
My wife dresses me.
She's on it. I love it. But I want folks to know how to follow you because you are giving these amazing truth bombs, sound bites of just incredible knowledge bombs that are so powerful that just creates another wave of curiosity and folks to be able to go further and further into their own education process. Where can they find you?
They can find me a lot of different places. They can find me at the williamscancerinstitute.com. They can find me on my personal Pre-scribed, pre-scribed.com. They can find me on my podcast, Pre-scribed by Dr. Nathan Goodyear. That's Pre-scribed by Dr. Nathan Goodyear. I do have a personal website called Doc Goodyear, DOC, Goodyear.com. And then the repurposing medication is off-scriptrx.com with its accompanied podcast. And of course, you can find me on all social media platforms. One of the ones we focus on a lot is Instagram, dr.goodyear. So that's where they can find me. And I got a big mouth, like I got big shirts, because I want to empower patients.
Yes.
Patients are the driver of their healthcare. A lot of them don't know it, but they are. And we as practitioners need to be the coaches that put them in the best position for victory.
Thank you. Thank you. Thank you. And thanks for bringing so much little nuggets of wisdom today. It's a joy.
Always a joy to talk to you.